All right. All right, guys. Hello, world, everybody in the seven continents. As you guys know, we try doing a Psych Life podcast every week, or at the minimum every other week. And today, once again, we have what I like to say is my partner and my co-host, William Bridge. How are you,
Hey
William?
Ron, how's it going, man? How are you doing?
Pretty good, pretty good. I'm sorry that in your South Beach visit during Memorial Day weekend, I couldn't see you over here, man. I'm sorry
Yeah, it's
about
all
that.
right. We'll have to reschedule for a different weekend and do one of these in person. It'd be a good time.
Definitely, definitely. So today, William, what I felt like we should have tried doing it earlier in April, but we got sidetracked, obviously, because both of us as clinicians, we have to work and stuff. But an autism podcast, one on autism spectrum disorder. I felt like this was long overdue, William, and I think the audience. It would be good for them to get information on autism spectrum disorder, which is a diagnosis which is being diagnosed a lot more today than it was 20 years ago. I'd say about William 20 years ago, maybe even 25 years ago, people didn't weren't even wasn't even aware of autism spectrum disorder. I think the rate was about 1 in 38, and in today's society, it's at a minimum of 1 of 69, which we will get into it. But William, I'd like to ask you, what experience do you have with autism spectrum disorder at the hospital?
Yeah, and just kind of following up with it's kind of the chronic question when you have an increase of any disorders, incidents, or new diagnosis each given year. The question always becomes: Are we getting better at diagnosing it, and that's why the numbers are increasing because the medical community is more aware, or is the disorder itself affecting more and more individuals? And usually, I think the answer to that is a combination of both. But I would say that personally, my clinical experience with autism spectrum disorder is, we do have 8 to 10 bed units in the inpatient setting that is designated in intellectual disability plus other psychiatric comorbidities, many of which times it happens that the patients also have a comorbid condition of autism spectrum disorder. So I see a little bit of it in the inpatient setting, and then I would say the other side of it is, more of a, pharmacomanagement in the emergency room for, behavioral disturbances. And then it's our job to decide whether or not they meet inpatient criteria or not. So, that's my clinical experience. What about your personal and clinical ties to ASD?
Oh, thanks for asking, William. My personal ties to ASD is my brother. That was the first time my family found out about the diagnosis. We had no idea what it was, but my brother was diagnosed with ASD probably when he was about 1.5 to 2 years old. I was probably about 12 and a half or 13 years old. And, my family had to readjust their style of living at the time. Therapy wasn't free every clinical session, because he engaged in with a therapist in applied behavioral analysis. They would think it was like about $105 a day per session. And so everybody in the family had to adjust. All of a sudden, I couldn't get those nice pair of sneakers I wanted anymore. That had to go towards my brother and his gluten-free diet. And we're going to get into all that. And I was also a behavioral technician, which I was an ABA therapist in training before I decided to go more towards the mental health route. I did that for about a year. So I do have pretty good experience when it comes to autism spectrum disorder. And William, to touch about what you said about whether is it that we're getting better at diagnosing, or is it that the prevalence rate really is growing because more and more people are experiencing the symptoms of ASD, right? But what about, it's interesting that you mentioned that. I was going to save that for later in the podcast, but what about the what people said, and like my professor says, can it also be that the DSM is making it the criteria a little bit easier to meet, which I'll be the first to say that autism spectrum disorder is a real disorder because I have personal experience not only treating others that suffer with the diagnosis, but like my little brother, seeing him. So, do you think that that's also a factor, though, that the DSM is changing the criteria and adjusting it in a way where more people fit into the paradigm of autism spectrum disorder?
Yeah, I mean, I think that the name itself, anytime you talk about disease or disorder that has put itself or have like varying degrees of functionality within that spectrum. So, you know, before DSM-5 came out, there was Asperger's, you know, and since the modification of DSM-5, it's kind of as though Asperger's were now under the autism spectrum disorder umbrella. So you have a whole other formerly separate diagnostic group of individuals that now fall under ASD. So I think that, you know, anytime you have a disorder that has a broad range of presentation, you end up with quite a significant amount of individuals that, you know, end up under such a diagnostic criteria, especially since, you know, the Asperger's group was, you know, a larger group that got grouped together with ASD. So, I mean, I think that that alone caused there, you know, to be more room for people to meet criteria. But you know, I think that anything in psychiatry and medicine alike, you know, there's never going to be any one reason something's going on. You know, it's always going to be multifactorial.
You know what, William? I appreciate that because I hadn't really given that part much thought. And you're right. In the DSM-5, they grouped other diagnoses like child integrative disorder, and I think there was pervasive disorder. I'm not sure if don't you know that name. I forgot the exact name of that diagnosis, but Asperger's definitely. So now they all fit under the autism spectrum disorder umbrella, and that would make sense as to why my professor said that. But that I never really given that much thought, and it makes sense now. But William, I think the best thing for us to do at the moment would be for us to use the American Psychiatric Association's definition of autism spectrum disorder, an association that you are very familiar with as a psychiatrist, and for the audience to know exactly what we're talking about and what the exact definition of autism spectrum disorder is. An autism spectrum disorder is a complex, and I'm quoting here, William, autism spectrum disorder is a complex developmental condition that involves persistent challenges in social interaction, speech, and nonverbal communication, and restricted repetitive behaviors. So they separated into three major parts: challenges in social interaction, speech and nonverbal communication, and restrictive repetitive behaviors. And we're going to get into each one little by little, William, because I think it's important for the audience to distinguish the differences instead of saying, oh, I have trouble reading other people, or I have trouble communicating. Does that mean I have ASD? No. I would just want to say for the audience there that all these diagnoses that we always talk about here, and it's just a conversation Dr. Bridge and I are having, is that we're just talking about the diagnosis itself. If you feel like you need to see a mental health provider or a specialist, you know, do not diagnose yourself. Let a specialist diagnose you. Anyway, so let's talk about the social interaction and communication problems. William, like I said, I have some experience in this portion because my brother growing up, you know, one of the difficulties was, and the family was worried about, was when he started school, because he had difficulty relaying what he needed. He wouldn't say it. If he needed to use the bathroom and the bathroom wasn't available, he wouldn't raise his hand to say, I need to use the bathroom. So it was difficult. He had trouble communicating with others. And what the audience needs to understand is that when someone has difficulty reading behaviors of others and interacting with others, and they have trouble communicating their needs, that presents a whole another series of difficulties, not only for the individual, but for the teachers, the parents, and the school officials in general. So in the hospital, what do you guys do when in the beds that you said that are filled? I know that um, there's the developmental psychologist, I think you said that is mostly associated with that. But what happens in the hospital when someone does meet the criteria for ASD and they're there and they have trouble communicating socially?
This is an interesting disorder in that I feel like, the inpatient setting is not the ideal environment to diagnose ASD. So if it is on the differential while we see them inpatient, I think this will come from a series of outpatient evals where you have, I think a big part of it becomes IQ testing, formal outpatient neuropsych testing, because anytime there's an acute situation going on, it's one thing if a patient already carries the diagnosis of autism spectrum disorder, and then we're just changing medications to help target different behaviors or self-injury or lack of sleep. I'm sure we'll get into a lot of the comorbid conditions you get with this, but usually it's behavioral management of an already diagnosed autism spectrum disorder, and if they don't have it as part of their discharge plan, we'll get them cued in with the right sort of outpatient testing to make sure we're on to the right diagnostic criteria. And it's a complex diagnosis that I would challenge anybody that thinks it can be 100% confirmed on the initial visit. I'd respectfully have to disagree with that because you need to see this type of social interaction abnormality. It's got to be in multiple settings as well. It's another big part of it, and it's hard to gather such a comprehensive history and illustrate the whole clinical picture after one visit.
And you say you challenge anybody that just diagnoses it after one visit because it has to be displayed in multiple settings. And that's so important, William, that you mentioned that. And that's why I really appreciate you doing this podcast, man, because you have a lot of knowledge, and it has to be in multiple settings because it can be a situation where, okay, when I speak in public, I become fearful and I can't communicate and I can't read social cues, or when I'm around a peer group, all of a sudden I become having social issues, and all of a sudden I get behavioral patterns that are uncommon for myself. It has to be in multiple settings, and the criteria has to be met using a specific assessment. So I appreciate you sharing that, William. But what's interesting about this diagnosis, William, is that over time, like I said, 25 years ago, not many people were aware of it, and the prevalence rate wasn't as high. And you said that the controlled setting like that in a hospital might not be the best place for someone that meets the criteria for autism spectrum disorder. William, I'm sure you're aware. Did you know that in about the 1940s and 1950s, those that were struggling with the symptoms of autism spectrum disorder, all of a sudden they were placed in psych wards and they were treated as if they couldn't function in society, and that was maybe not the best place for them at the moment. So society really has come a long way when it comes to those diagnosed with autism spectrum disorder. So
I had heard that, and the word autism itself kind of comes from, if you break it down, the auto is self, and it's the autism word basically comes from self alone. So back when we didn't know much about the disorder itself, we just knew that maybe this patient was different than the norms of society. It's kind of as though they, you take the lack of social understanding coupled with some odd, or repetitive behaviors, coupled with poor communication. And it's as though, these patients were in a world all their own, which is where the name kind of came from. And I think that, back then they didn't really know what exactly to do. We didn't know what that was, how to treat it. So, unfortunately, a lot of the answers for mental health at that time, and especially earlier, were to almost just remove them from the everyday world of normal society because they didn't fit in. So we've come a long way, but I think we have a long way to go at the same time.
And there have been many people diagnosed with autism spectrum disorder that have innovated for the world and created stuff for us to use. So I'm going to go on, William, and we'll go back to the symptoms and the repetitive behaviors, maladaptive behaviors, and why applied behavioral analysis is the most research-based treatment for those diagnosed. But one thing I want the audience to know is that those that are struggling with the symptoms of autism spectrum disorder, part of the reason is because their genes mix with the environment, and then all of a sudden something happens that they start meeting the symptoms. But their brain tends to be, I don't want to say abnormal, but atypical compared to the typical person. And some of the structural differences seen in people with autism also appear in brain scans of some controls. So I'm reading here, William, I was reading a research article from the spectrumnews.org, which are always posting new research concerning those within the autism spectrum disorder. And some of the brain changes, they tend to have a thicker frontal lobe. And that would make sense because if you have a thicker frontal lobe, that means there's a lot more neurological connections involved there. And the wiring tends to be not as typical as a typical brain, I guess. And so with that comes, and the connection to the amygdala, which is the emotional part of the brain, the one that controls the emotion, it tends to be a little odd. And that's why sometimes you'll see someone that's struggling with the symptoms of autism spectrum disorder, they'll get excited out of nowhere, or they'll get excited for something that a typical person wouldn't get so excited about. And that's how these maladaptive behaviors come about, that when they get so excited, all of a sudden someone might experience flapping, or they get so excited that they start picking their eyebrows or their eyelids or biting their hand. And these maladaptive behaviors can be detrimental because they're hurting themselves, but they don't even experience the pain at the moment because of the stimulation they're experiencing.
Yeah, I mean, absolutely, man. I think that, we've talked about this before, but the more that we learn about these neuropsychiatric disorders, the more we can comprehend and process some of these structural changes. Just as you were talking about some of the, the frontal lobe neural networks, as well as the amygdala. These patients with autism spectrum disorder, they have 10 times more likely subsequent diagnosis of epilepsy and seizure disorder than children or adults without autism spectrum disorder. So, or versus the general population would be another way to say that. So it tells you there is a structural difference, that, this tenfold higher likelihood of epilepsy. That is not a coincidence, right? So we know that there is electrical signaling differences, there is physical structural differences, and all of which will contribute to some of these social communication, verbal differences that cause them to meet criteria for such a disorder.
Yeah, so those within the autism, those that meet the criteria for autism spectrum disorder, have 10 times more likely to experience epilepsy?
Yes, then if you compared, the general population ages, let's say 5 to 18, so much higher incidence of epilepsy. So when you see numbers like that, that there's correlation. Can't say that one causes the other, but in some way these two are linked to one another.
And
So.
and when we and in here in this research article, and I'm not sure if this has directly anything to do with it, but it's all integrated together. Those diagnosed with autism have a slightly thinner temporal cortex, which is a large region associated with processing sounds and speech. That means that those that are diagnosed with autism, the way the sound and the speech, it's almost like they're simulating everything very fast, and they can't handle the processing of these stimuli. So and I'm reading this, William, for those that I get people all the time on my Instagram saying, oh, where's the research to back this, or psychology isn't fully a science. And so sometimes I have to read these facts because it is a science. It's just that there's a lot, it's not so much cause and effect, or it's not so inductive reasoning to say. But we're going to move on here, William, and I wanted to talk about some of the signs and symptoms and go back to what we were talking about. When we talk about social communication and interaction and difficulty with social communication that those with autism experience, what does that mean? What are some of the exact things that we're talking about? Well, making little eye contact, tending not to look at people or listen. Sometimes those with like as young as 2 years old, they still have trouble processing what their name is. And if they do process what their name is, they don't understand to look at the person that's calling them by their name, or having difficulties with the back and forth conversation. So, William, you see how you and I are having a conversation here about autism. Those that are diagnosed with autism are going to have difficulty continuing a conversation. It's very rare, and it's something that therapeutic approaches such as applied behavior analysis sometimes can help with that through a reward system. And we're going to talk a little bit about that too. And also, I'm just going to throw this last one out here, having facial expressions and gestures that match what is being said. I see this with my brother all the time. He may be sad, but he doesn't display it, or he may be happy, but he still stays with the same neutral face. And he loves it. He calls it neutral face. So some of these patterns, they're difficult for them to grasp. And hopefully as science evolves, we can begin to apply more treatment than what's needed. But can you shed some light on the medication portion of those being diagnosed with autism? What type of medication? Because I know my brother takes, for example, about 5 or 6 different pills, and I'm curious as to not what exactly it is, but because I know that's what some of them are, but why is it necessary?
Sure. So, I mean, and again, this will always, I think the three, maybe 4 classes that I'll just briefly touch on here are usually going to be targeting more than one specific, behavior, symptom, whatever you'd like to call it. So starting off, what I'll say is that due to the high comorbidities of, seizure disorder, a lot of times we will use, depending on patient's age and weight, lower dose anti-epileptic medications such as like Depakote or valproic acid. This can help, uphold mood stabilization. It can diminish any component of anger and irritability. It can help with, some of the impulsive behaviors. So, and at the same time, it would also help to prevent any seizures, and that can help keep the patient out of the hospital. So anti-epileptic or anti-seizure medications such as Depakote are commonly used. We'll also use lower dose or starting dose SSRI, so your serotonin reuptake inhibitors. And really, again, this is more so to target any impulsivity, any comorbid depression, anxiety, and those patients that I've seen tried on some of the more popular and better studied are Prozac and Zoloft. Usually do quite well on those. The third class that I think is worth mentioning is the stimulant. So a lot of times, dependent upon the structural changes of the brain and how high functioning the patient is, are they able to enter into what we call in the Carolinas like a day program, somewhere where they can go for Monday through Friday to have structured activities, or events, or outings with other patients of the similar functioning. Stimulants can help with focus, attention, alertness, in the kind of like classroom environment. And then depending on how everything goes during the day, some of the times we'll also need to regulate sleep. So sometimes it's not unlikely that these patients are on different prescription sleep aids to make sure that, the last thing the autistic brain needs is sleep deprivation. So if it's the, repetitive behaviors or stimming, or some of the type of emotional derangement that can be present, if that is inhibiting sleep, doesn't, I always say it doesn't matter what, your psychiatric history is. If you're up all night, the next day doesn't go well. So, we'll treat sleep as well, because that's a common finding. So it's kind of a four-prong approach to our treatment. But the first thing is confirming the diagnosis. You want to know what you're treating and kind of take it from there.
Yeah, and it's funny how you mentioned stimulants, and autism, and at first when you said the I think it was the third category, which was stimulants, I was a little taken back by it, because I was thinking to myself, how can someone with autism need stimulants to be engaged, or to be to be fully, like, they need that energy? But and then it's so funny, William, it doesn't matter what title someone gets or anything, but autism spectrum disorder is exactly that. It's a spectrum. Not every case I've seen, it's exactly the same. So I can understand how maybe one individual may need that type of stimulant to be more engaged in the classroom. But my brother, and I'm just going to mention something personal here, he was given, I think it was Adderall at a smaller dose for classroom focus. And he was also given a mood stabilizer. But there was a lot of issues in the beginning with the drugs that they were prescribing him, because they had to get the right mix for him. I remember sometimes they prescribed him a drug for a specific reason, and then all of a sudden that drug made him less focused in the classroom. And there was it took a while for it to get the right mix. But for those saying that medication is not needed, yes. And we've talked about it on our other podcast, William, and I know you remember that. The best mix is often therapy and medication at the same time. So autism spectrum, that is just that, guys, a spectrum. Not every case is the same. But while scientists don't know the exact causes of autism spectrum disorder, research suggests that genes act together with the environment to influence the effect and development of those experiencing ASD. So William, when we talk about the cause of autism spectrum disorder, there we still don't know exactly what the cause is. We just know that it's the genes that interact with the environment, and at some point the symptoms are experienced. And the reason I mentioned the cause is because there was a lot of talk in the beginning, William, about 10 years ago, and there's still this myth out there that vaccines cause autism. And it doesn't. I've read it in so many books, William, that there's no research to show or display any sort of correlation between vaccines that a person has gets from the doctor and autism. There's no correlation. There was only one study a while back, William, where someone falsified or made false data. Like, they created this false data, this false narrative that there was some sort of association, and that's how this myth got started. Have you seen people still believe in this myth? Or at least there's no research to back it. So, but as of right now, to me, it's a myth.
Yeah, I mean, I think that, so quite a few years ago, the largest study was done, and there may have been a bigger one since, that basically, took, up to 20,000 total children and divided them in whether they were vaccinated or non-vaccinated. And it showed that the prevalence of autism was equal. So it had, the biggest study at that time showed there was absolutely no link between being vaccinated and subsequently being diagnosed with autism. So, I mean, it's one of those things that, still the idea itself, you'll still hear it in passing, but I think that it's important to emphasize that, if there is something that the patient or patient's family feels caused autism, remember, that's not autism. That would be some kind of, substance-induced brain anomaly. That would not be. So, to say my son or daughter got this vaccine and now they have this, if you look at all the criteria and everything that we have outlined and defined as autism, there in no place does it say, there's a substance or medication induced form of this. If that's the case, if there's brain changes from something that was received from an external environment, then we're talking about something else. It's kind of like we have a depression that is just major depressive disorder, but we also have like a mood disorder secondary to substance such as alcohol. So there's some definition of terms things there, but I think the big picture is, I think you've seen what's going on, and some of the anti-vaccination waves not too long ago, and we've seen a resurgence of measles and some really dangerous things from not vaccinating. So we do get a lot more vaccines than when I was a child. Give a lot more. There's a lot more that exists. But do we have the data to say that's why autism is picking up? No, we've actually the data says that it's unrelated, if anything.
Unrelated, and no correlation whatsoever. No correlation whatsoever. And there is one correlation though, William, and it's been in a couple studies. It's even in the National Institute of Mental Health on their page, and that's the correlation between low birth weight and autism. And it doesn't mean, and the correlation is very small, but there's a correlation that's above the threshold that says that there is a correlation. So not causation. That doesn't mean correlation and causation are two different things. Causation means X causes Z. X and Y cause Z. But correlation means that there's some sort of association, and the association is small, but there is an association between low birth weight and autism. And it's funny, my brother was born about a month before he was supposed to. But that doesn't mean that that led to him having autism. It just means that it could be one of the many variables contributing to it. So that's an important. Now, William, now we're running a little short on time. So I want to get right to the treatments of autism, if you don't mind. You touched
Sure.
on medication. You touched on
Yeah.
medication. Now I wanted to touch on applied behavioral analysis. And this ties into the repetitive behavior part that we talked about that the DSM-5 mentions. And when we talk about repetitive behaviors, we already mentioned what it is. Those diagnosed with autism, they tend to stick to a structure. They tend to stick to what they know. They like patterns. They like knowing what's going to happen. That's something that from my experience I've seen with my clients. With the repetitive behaviors, sometimes the stimuli are so much for them, due to factors like their temporal lobe's thinner, their frontal lobe is thicker, that they start, let's say, flapping, or they'll start picking their eyebrows, or they get so stimulated from the stimuli that they'll bite their hand, and they're basically injuring themselves. It's almost like their way of controlling that stimulation that they feel inside, that their brain um, is wired to do almost. That's why applied behavioral analysis has been so beneficial for those diagnosed with autism, because it works on stopping their maladaptive behaviors. It's all about the maladaptive behaviors, and what they do is they use consequences to help them extinguish these maladaptive behaviors. And I'll give you an example. I remember when I was working with those with ASD, I would sometimes, the whole session, let's say if I was there for 2 hours, would be for them not to engage in the maladaptive behavior they're experiencing. So I'll give you, for example, I had one client that used to bite his hand a lot. So he'll get stimulated when he got something right or he did something good, and he'll want to bite his hands. Well, I got his favorite toy, and as the behavior, and every time we did an exercise, I would give him the toy if instead of him engaging in the maladaptive behavior. And over time, I would hope that that would become extinguished. But you know what I would often find, William, that they would pick up another maladaptive behavior in the process of extinguishing one. It's almost like a lifelong cycle for them. And after he discontinued. Eventually, after 2 months, his behavior of biting his hand was extinguished. But all of a sudden, he picked up a maladaptive behavior of picking his eyebrow. And so that's why ABA has been so effective, because it works on extinguishing the maladaptive behaviors. And maladaptive behaviors, whether we want to admit it or not, William, has a perspective from others. It gains a perspective from others, a negative perspective. Oh, this person can't function in society. This person's got an issue. When you extinguish it, people can't tell, because ASD is not something that you can just look at and tell. You even mentioned that you need more visits than just one to be able to diagnose it correctly. So
Sure.
when it comes to ABA, that's the most research-based treatment, and it's all over the country. Although now there's other treatment modalities. I think there's one where, for those, I don't know the name exactly, but it's picking up steam, where all the clinician does is they work with the client and they let the client lead the way and play. But it doesn't really extinguish any of the maladaptive behaviors. It just lets the child with autism feel as if they are part of something. They just, instead of just feeling always excluded. So those are the two types of therapies that I've experienced with ASD. But the medication part is so crucial. That part can't be denied. And my brother, he discontinued his therapy with ABA once he was 13, but he still continues to take medication. It is for sure. It is a for sure thing. So, William, thanks for today's podcast, man. I know today it was kind of a short podcast, but we'll do something else next time for the audience that's a little longer, bro. And I just want to let you know I really appreciate you coming on. And I think the audience appreciates you as well, man, because you have a lot of knowledge that you bring to the table when we're talking about all these diagnoses within the DSM and all these topics. So I just want to tell you, man, I really appreciate you, bro. Okay.
Well, yeah, man, it's my pleasure. I appreciate you having me on. And I think, definitely this is every few podcasts we see that, probably some of these disorders or discussions need a second part. I think this may be, one of those, but, I'm glad we got to take care of talking about autism and make sure that we field all the questions that come in after this goes up. So thanks again for having me on, man, and we'll talk about a different topic next time. I guess we got to figure out what that is.
Yeah, we will. I appreciate you, William, and thanks, audience. Okay, everybody out there that's listens, I appreciate it. See you.